So just to demonstrate all this in a live scan, it's not really live, of course. This patient was 39, had severe dysmenorrhea, had bad menorrhagia, and then really awful constipation, 6 times a day, just small pellets, no children, no surgery, CTKB was normal, and she had a raised CA125. So look as you insert the probe, and then almost immediately as I got to the cervix, there's resistance. This is a frozen pelvis. So that took about 1 second. Then we're going to be disciplined, do it in a systematic way. So looking at the uterus, also looking at the cervix importantly. And here we've noticed some minor diffuse adenomyosis, and then also a little bit of what used to be called superficial adenomyosis, but it's probably a little bit of deep endometriosis actually. The endometrium is thin on day 1. The endomyometrial junction's not all that clear. And then looking at our ovaries, they're probably bilateral small anechoic endometriomas. They are low in the pelvis, but not kissing. Here I've rotated on the torus, and you can see that both ovaries are adherent to the uterosacral ligaments. I would have proved that by some very gentle sliding sign. So what have we got so far? We've got that uterus with a bit of adenomyosis, a nodule of superficial adenomyosis anteriorly, just there. We've got these bilateral low ovaries with endometriomas, and then something else caught our eye. And it was a bowel nodule. So we're looking at the area of the torus now, but we'll start with the bowel nodule given that it's shouting at us. Here I am measuring the length of it. I like to measure it along the length of bowel that's affected, and the depth doing only the disruptive muscularis. The width, that's the width of it. I've just rotated on that nodule, and then that is the bowel width. So you can see it's nearly 50%. Where is it? The level, it is, there's the torus again. That's where the bladder sort of adheres to the uterus, internal os torus. You can see this is lower rectum and upper rectum. And the angle, if you measure it that way, is more than 90 degrees. But it does look stenosing if you look at the bowel diameter here and just above the lesion, it's halved. Where was it? As I was inserting the probe using extended view, this was 110 millimeters. So this is the beginning of the nodule. Patient's head is here. So here I tracked muscularis again, and then you can't track it anymore there. So that's the first anal curve, so 110 millimeters. So just looking again at this bowel nodule, looking for all the other bits of anatomy nearby, you can see that there's retrocervical fibrosis, and then you see this very faint, dark, deep endometriosis just there. You can also see that the posterior vaginal fornix is normal. So there's that deep endometriosis at the torus extending into the uterosacral ligaments like that. And the vagina looks normal. So the overview was of ovarian endometrioma, retrocervical fibrosis, bowel nodule, deep endometriosis, and we're in the anterior fornix again. So a frozen pelvis with retrocervical fibrosis. Then don't forget the bladder. By the end of the scan, most people have some urine in the bladder. You don't have to have a lot, a bit more would have been nice here. I can see that there's that nodule of adenomyosis stroke deep endometriosis with a lot of fibrosis and adhesions around it, and if you hunt, you'll find some deep endometriosis to one side and some deep endometriosis toward the other. And at the end of the scan, I like to draw patients a cartoon. People find it easy to understand what I'm trying to explain to them. So here would be that nodule of superficial adenomyosis, the deep endometriosis associated with it within fibrosis. At the level of the torus, we had the nodule of deep endometriosis plaque. There's the ovarian endometrioma adherent just close to it. This is that bowel nodule that spans across the level of the torus, so it's lower and upper rectum, and then these dense adhesions, so the peritoneum is only to there. Then I like to say in the longitudinal view, coronal really, There's the level of the torus. The ovaries are both adherent to it. That's a deep endometriosis. And I think it helps to explain that you cannot get this view at laparoscopy. So in my report, severe endometriosis, minor diffuse adeno, some superficial adeno with deep endo in the vesicouterine pouch with adhesions, bilateral small endometriomas adherent to the uterosacral ligaments not kissing, large plaque of DE in the torus and USLs, a large stenosing bowel lesion where it is, and an obliterated pouch of Douglas, a frozen pelvis. So these are some great resources, some online stuff, this wonderful book. This is a great website by Sophie Peasons with lots of examples of how to diagnose endometriosis. And then, of course, on my website too, there are lots of step-by-step videos. Patient voices, so important. This book is unbelievably sad, and the Private Parts by Eleanor Thom contains lots of really good information for patients with endometriosis, and I think we should all be handing these out freely if possible. So in conclusion, you can see endometriosis on ultrasound, but a lot more training will be required before it can be done by everyone. Transvaginal ultrasound is great for planning surgery, and expert transvaginal ultrasound is great for understanding patients' pain. Seeing is believing. Thank you.